Are you able to see the slides? So you
Yes,
can
sir.
straight away go for one lung ventilation indications. As I said, one lung ventilation, there is no need to define or describe what you are going to do. If you say the indications, then you can understand why you need to do one lung ventilation. So the indications can be classified into absolute indications to prevent damage or contamination of the healthy lung, as in cases of lung abscess or massive pulmonary hemorrhage, where one lung is affected, and by trying to operate on that lung, there's a chance that either the pus or blood can go into the normal healthy lung and contaminate and destroy that function also. Or you can do it as a control for distribution of ventilation, like in bronchopleural fistula, where by doing a ventilation on the fistulous lung, all the gases will always take the path of least resistance and go through the fistulous tract, and ventilation will be very difficult. And the major cyst or bulla or traumatic bronchial ruptures, all these conditions require isolation of that injured lung or the fistulous lung, so that you can ventilate the normal healthy lung and operate and remove the fistula or the bulla and restore the function of that diseased lung. And to facilitate single lung lavage, as in cases of cystic fibrosis or pulmonary alveolar proteinosis, then there are relative indications. So the relative indications are to improve surgical aspects, which is a strong recommendation. The conditions like thoracic aneurysms, pneumonectomy, lung volume reduction surgery for severe emphysema, these are all some of the surgeries where you have to isolate the diseased lung and ventilate the normal lung. And minimally invasive cardiac surgery, upper lobectomy, video assisted thoracoscopy, these are all also conditions where you may need to use a one lung ventilation. Then the weaker recommendation for surgical access are esophageal surgery, middle and lower lobectomy, mediastinal mass reduction. In these cases, majority of them can be maintained with the double lung ventilation itself, but occasionally they may request for the isolation of the lung. Then in intensive care, this is a newer indication with a lot of lung transplantation going on. In intensive care ventilation, if a patient has got a single lung disease, it may be desirable to ventilate the lungs independently using two ventilators, so that the normal lung is not subjected to high pressure required for ventilation of an abnormal lung. An example of this is a single lung transplantation. So this is one of the current developments in the transplant history, where single lung transplantations require to be ventilated using a WM tube independently with two ventilators. One the normal the already existing lung, and the second is the transplanted lung. Now, what are the techniques available for one lung ventilation? As you rightly said, there are three different methods to isolate. One is the commonest is the double lumen tube, then bronchial blocker, and the single lumen tube advanced into the bronchus. Coming to the double lumen tube, a bifurcated tube which separates tracheal and endobronchial lumens, which can ventilate either lung independently. The tracheal lumen designed to terminate above the carina. That is how the tube is designed. While the bronchial lumen is angled to fit into the appropriate side, because we have a right-sided tube and a left-sided tube. And the examination, they commonly give you these tubes and ask you to identify whether it is a right side end of the lumen tube or a left-sided tube. And the bronchial cuff and the pilot balloons are usually color-coded with the blue color for easy identification. And the right and left-sided, because of the anatomical differences, are designed separately to lodge into the respective bronchi. The right main bronchus, as she said, is shorter, wider than the left main bronchus. It has a lesser angulation. The left side is so the right upper lobe bronchus takes off at a very close origin. So if you don't place it properly, there is a chance that the right upper lobe will collapse and cause more problem. So this picture will tell you how these right-sided tubes are there. So you can see it will have a right upper lobe lumen, very close to the bronchial lumen, and this is the bronchial cuff, which will have a small indentation like this. And the length from the tracheal cuff is very, very short and right-sided tube. So in the exam, they give you that. First, see the length of the portion of the endobronchial portion below the tracheal lumen, tracheal cuff. Then you can easily identify. And this is the right-sided tube. And you can see this is the left-sided tube, where there is no opening for the upper lobe bronchus, and it has a fairly larger length compared to the smaller length of the right side. And this is the tracheal lumen with the tracheal cuff, bronchial cuff, which are all connected to. So this is the left-sided lumen tube picture. And before using this lumen tube, you have to ask the following questions. What type of tube is needed for the surgery? Whether it is right side tube or left side tube. So specific indications for usually they prefer to use the left-sided tube because of the longer bronchial length and the chances of occluding the right upper lobe uh, branch is very less if you do a left-sided replacement. So there are specific indications to use right-sided DLT. They are like surgery involving the left main bronchus, like left pneumonectomy, like lung transplant, tracheobronchial dissection, or left-sided thoracic thoracoscopic surgery, or distorted anatomy of the left wing, aneurysm or descending aorta, or tumor compression. So the indications for using a right-sided tube are very, very limited. And what size tube to choose? Adult usually 35, 37, 39, 49 French. What is the difference between French gauge and SI unit? Dr. Chaitanya, what do you understand by French gauge? What will be the outer diameter of the 41 or 39 size tube?
It is 10, sir.
It is French gauge divided by 3, okay, outer diameter in millimeter of any tube, okay. So any tube, whether it is endotracheal tube or endobronchial tube or Polish catheter or nasogastric tube, which are all measured in French gauge, is number in French gauge divided by 3 gives the outer diameter in millimeters. Okay, that is the calculation. So if you use a 39 French, 39 by 3 is 13 mm is the outer diameter of the tube. Okay? So you need not waste too much time as to how to select the size of the tube. You can just say adults are commonly use this thing, and the French gauge is the external diameter multiplied by 3, or the number divided by 3 gives the external diameter. A properly sized DLT is the one that passes easily through the glottis and advances without resistance within the trachea and goes into the bronchial component without difficulty. So that is how you choose the tube. Even though you choose between these sizes, correctly selected tube should easily go through the trachea as well as into the bronchus. And the most accurate method of selecting the size is measurement of the left main stem bronchus diameter from a computed tomographic scan. So this is how the modern preoperatively can do a CT scan and make a measurement of the left main bronchus and then select the tube accordingly. And the traditional approach is to use between 37 and 39 for average size female and male patients respectively, and the size up and down is used for larger or smaller patients respectively. Okay? So you can see this is the actual Shiley company tube, and you see the size is written here 35 French, and it is written left side. So if they Viva exam, if they hand over a tube like this, you can calmly read all these points and then answer the questions. Even if you have not used them or had a chance to do an endobronchial or a WM tube intubation during your training period, can safely read all these things and then identify the various components. And this is how the two tubes, the right side and left side. You can see the classical difference in this tube. The right upper lobe, even like a Murphy site is here, it will not be present in the left side of tube. So then the third question is, how is it inserted? Check the integrity of tracheal and bronchial cuffs before you start. Lubricate the outside of the abdominal tube. Lubricate and insert the intubating stylet, which is usually provided, and insert it up to the endobronchial lumen. And then the stylet can be pre-shaped to aid the placement. Then perform, after induction and relaxation, perform a direct laryngoscopy as you do for a regular endotracheal intubation. Visualize the glottis. Advance the DLT till the endobronchial tube has passed beyond the vocal cord. Then remove the stellate. Then rotate the DLT 90-degree clockwise or anti-clockwise depending upon that. Normally, have to remember that is, if you are going to do a right endobronchial intubation, right side abdominal tube, you rotate the tube right side. If you are going to use a left sided tube, you rotate it 90-degree left side. That way you can easily remember, and pass the tracheal cuff beyond the glottis until resistance is encountered. So keep on pushing the tube until the resistance is encountered, and the depth usually correlates to the height of an average patient. And the formula is 12 plus patient's height in centimeter divided by 10. Okay, so that is why she said 170 centimeter patient, 17 plus 12 will be the. And whose name that formula is named after? Any idea, Chaitanya?
Sir, I don't remember, sir.
It is called Perry's formula, Perry. So a person called Perry only formulated that. So if a patient's height is 18, then it will be 18 plus 12. 180 centimeters, 18 plus 12. So height of the patient in centimeters divided by 10 plus 12 is the formula. Then how successful is positioning of the DLT confirmed? Sequential clamping and auscultation, and the three-step method, which inflate the tracheal cuff with minimal volume, seal the glottic airlet, and perform positive pressure ventilation. And you must be able to hear the air entry on both sides. Then clamp the tracheal tube from the breathing circuit connector. Disconnect this from the tracheal lumen and inflate the bronchial cuff and then ventilate that. You should be able to use hear the exit sound only on the right or left side according to the tube that you are used. Then release the tracheal lumen clamp and close the port. Auscultate to confirm the function of bilateral air entry. So these are the three-step method called for proper position. But fiber optic visualization is considered as the golden standard for the correct position estimation. Now, what are the problems related to use of DLT? One is malposition, two is airway trauma, three is tension pneumothorax, the dependent lung because of the high ventilating pressures. The next option is, if you don't have the WM tubes or training in that, you can go for bronchial blockers, which is an alternative technique for lung isolation. And these are the various types of blockers, like Cohen, Fiji blocker, and Uni blocker. So they can also provide selective lobar collapse also, and it is placed intraluminally within the single lumen tube, like the coaxial circuit, or placed separately adjacent to that. So this picture will tell you this is the yellow line is the blocker which has gone through the normal endotracheal tube into the left main bronchus. Here it has been passed outside by the side of the endotracheal tube. It is not going through the lumen of the endotracheal tube. It is going. So if it goes inside, it is called a coaxial insertion. If it goes outside, it is called para insertion, paratracheal intubation or insertion. So this is how the whole thing is placed. And then lastly, central limb tubules also is used, which are placed into the endobronchial tube and cause, it may be preventing selective ventilation and collapse of the contralateral lung also possible. It is very, very rarely used unless it is an emergency or a very extreme difficulty in using a double lumen tube. The use of single lumen tube for one lung ventilation is a very rarely practiced technique. So these are the advantages and disadvantages. And commonly, once you do one lung ventilation, because of the main problem is you should have a very strong hypoxic pulmonary vasoconstrictor reflex, because you are not ventilating one lung, and but the perfusion to that lung is going on. So a strong hypoxic pulmonary vasoconstrictor reflex will divert all the blood that is coming to the unventilated lung to the normal side and prevent a hypoxic mixture happening. So if that protective phenomena is not happening properly, then patient will immediately desaturate. So when you use the double lumen tube or endobronchial tube, some patients who have already compromised lung function will immediately desaturate. Whereas a patient with a longer healthy lung without other comorbidities, they may have a good hypoxic pulmonary vasoconstrictor reflex, and they may not immediately desaturate. At the most, their saturation from 98, 99 may come down to 89, 90 like that, and remain stable like that. Whereas other patients with compromised lung function will immediately desaturate. So that is the behavior or pattern. So immediately after initiation of one lung, there will be a fall in arterial oxygenation, but the saturation will gradually pick up as hypoxic pulmonary vasoconstrictor reflex increases. And HPV is characteristically biphasic, with an early response beginning within the first few seconds to reach a maximum in about 15 minutes, followed by a second phase that begins in about 30 to 40 minutes later to peak at 2 hours. So majority of healthy lung patients will tolerate one lung ventilation without gross desaturation. So the safest lower limit of O2 saturation, if it is around 90%, you can accept that and continue with the ventilation. But hypoxemia during OLV in most cases respond well to some of the following simple interventions. One, so this is a common question they will ask you in the exam also, and it is easy to write this much answer in your theory paper also. Increase the FiO2 to 1. This can be employed in all patients except those who have received bleomycin for malignancy. So if you are going to operate on a patient who has already received the chemotherapy in the form of bleomycin, then FiO2 should not be given if it cause other complications. And then recheck the position of the DLT or blocker to rule out that malpositioning. Third is ensure the patient hemodynamics are acceptable and cardiac output is normal. There should be no hypotension or dehydration or inadequate mean arterial pressure. Perform recruitment maneuvers to the ventilated lung, which may be, however, causing transient hypotension or worsening hypoxemia if more blood is diverted. Then adjust the PEEP to the ventilated lung, and you must exercise caution in patients with COPD. Insufflation of oxygen followed by application of CPAP to the non-ventilated lung, and the intermittent reinflation of the non-ventilated lung, which is permitted. You can restore the HPV reflex for better repeated with hypoxic exposure. Then mechanical restriction of blood flow by clamping the pulmonary artery. Can request the surgeon to clamp the pulmonary artery going to the operative lung, which is not getting ventilated. And in worst case, if the patient desaturates very badly and goes in for other complications, resume two lung ventilation as soon as possible. These are the 9 things that are expected out of you as an answer, both from theory point of view as well as from practical point of view. So I think this much of description is more than enough for this question. So write about the indication, available equipments for that, and of course you can add a little bit of physiology of one lung ventilation, what Dr. Chaitanya described. what exactly happened, but we must write more about the hypoxic pulmonary vasoconstrictor reflex, which is the most important protective reflex, which guards against hypoxemia in majority of the patients. And then the smaller description about how to place the tube, identification of the side indications. So if you write this much, I think that will take care of the question on one lung ventilation. We can finish this answer within the given time also.
Thank you, sir.
Okay, thank you. I think already we are 8 o'clock. However much we try to rush, we are not able to complete all the given questions within the time limit. So we will have to postpone the next demand by Richard to next class about